camera. I act as a camera. And pass the visual signal to the brain. And brain processes in the form of an image. In the form of an image. So, there are some unique features in this part. There are some unique features. What are the unique features? First is that I have a convex lens. I have a convex lens. And that convex lens, once that forms an image of the retina, what type of image will it be?
Inverted.
It will be inverted. And that inverted image goes to brain. That goes to
Brain.
and plays the digital red cell. That is a great image. This is a unique system, visual system, which normally in the physical world is difficult to see. Number one. Number two, other important fact is that it is a field of vision. It is a field of vision. And this field of vision, we have two eyes. We have two eyes. And when we see this field of vision, some field is clear with the right and some field is clear with the left. Suppose this field is the right. This field is the left. In between there is a word between the two visual fields. What is the advantage of having two eyes or two this? What is that?
Wide range of vision. Wide range of vision.
Why is it vision? There is no. Yes. That's called stereoscopy. That person. Suppose that woodlock is slightly away from that glass. In order to appreciate that, you need a binocular vision. Now, when you see the corner, you cannot appreciate that. You see the other eye, you cannot appreciate that. But once you see the corner, you can see that the woodlock is slightly away from that glass. This is called depth of perception. This is called depth of perception or stereoscopy. That's no direction. If we go to see, we have this spectrum. We have this spectrum. And this spectrum stimulates what? It passes through the pupil, it goes to the lens, it follows the retina. What it will stimulate? It will stimulate photoreceptors. It will stimulate photoreceptors. From the photoreceptors, it will go to the bipolar cell. From the bipolar cell, to the retina, it will go to the ganglion cell. And from the ganglion cell, it will go to the optic nerve. So, if you see photoreceptors, what are the names of photoreceptors?
Rods and cones.
They act as receptors. Receptors for stimulus. Receptors for stimulus. The medium skin receptor. For that, pain, vibration, like that, we have visual receptors. They are in the retina. They are in the form of rods and cones. And once rods and cones are stimulated, they stimulate the bipolar cell. They stimulate the
Bipolar cells.
So bipolar cells are first order neurons. They are
First order neurons.
then from the bipolar cell, it will go to the ganglion cells. Then they are the second order neurons. They are the second order neurons. From the ganglion cells, they have long axons. They have
Long.
axons. And they go to optic nerve. That is the second order neuron. That is the second order neuron. Why bipolar cells are called bipolar? Because they have two.
एक axon और एक dendrite.
One towards the photoreceptor and one towards the ganglion. You understand? That's why they are called bipolar. So I have given you an idea how visual system acts as the main interpreter system. And number second, what is the advantage of having both eyes? Two eyes. And what is the importance of having a depth perception? And number two, I have told you about
Temporal retina.
The nasal retina sees the temporal. And the temporal retina sees the nasal. You understand?
Yes.
So, retina, nasal retina sees distant, and temporal retina sees distant. So, temporal fibers will see nasal retina. Nasal fibers will see temporal. You understand? Okay. Same way, superior. It will see the inferior. 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 It will see the superior. Sorry, inferior retina. It will see the superior. Okay? Understood? Any confusion? So, that's why. So, once the optic nerve, this is suppose the right eye optic nerve, and this is the left eye optic nerve. It is two parts. One is the nasal part and one is the temporal. One is the nasal and the other is the temporal. Same way here, nasal and temporal. Once they go. Suppose from here, it goes. Once the optic nerve leaves the eyeball at the back of the eyeball, it becomes intraocular. It becomes intraocular. First it is intraocular. That's very small, around 1. Then about 30 mm, it becomes intraorbital. Once it leaves the orbit, it becomes what? It becomes cranial or canonical. First canonical, because this is optical canal. This is optical canal. Around 6 to 10 mm, it is in that intracanonical. Okay? And after it leaves that canal, it goes to the brain. That's called the intracranial part. That's also around 10 mm. How much? Around 10 mm. So total around 30 plus 10 plus 10, around 50 long. So optic nerve is around 50 mm long. 1 mm is in this. I know. 30 mm is in the orbit. That's more. 30 mm is more. Why God gave it 30 mm in the orbit? Because you want to lose. Keep it loose. So that there is a strip of eyeball, it will not break. Okay? So it is a sort of a spinal course in the heart. It is not a tight like this. Okay? So it is a loose course in the heart. So it is around 30 mm, then we have 10 mm in the canonical part, then we have 10 mm in the cranial. Okay? So total around is 50. So once it reaches, then it goes to this is called the optic chiasm. It's called optic chiasm. It's a very special
Process.
It's called optic chiasm.
Yes.
Optic chiasm is near to what? It's there at the cell or pituitary star. Okay? You understand? So this is there at the cell and optical chiasm is arose. Okay? So once there is some pituitary tumor or this, that can erode this optic chiasm, and that is called visual field symptom. So this is most important clinical cause of the loss. Once suppose these nasal fibers, they go and the nasal fibers cross here. Here these nasal fibers cross here. Nasal part crosses the optic chiasm. Temporal part does not cross. So once the optic chiasm is here, so these temporal fibers will go straight like this, and these nasal fibers will go to the opposite side. So this is called what? This is called optic nerve. This is called optic nerve. This is the right optic nerve. This is the left optic nerve, and this is the optic chiasm. Once this then leaves, it contains the temporal organs, nasal organs. Okay, temporal fibers of this and nasal organs is called optic tract. It's called optic tract. So once optic tract goes posteriorly, it goes back. This is the LVP. That's called lateral penetrate body. Once from the lateral penetrate body, it goes back. It forms what? Optic radiation. It forms optic radiation. Once the optic radiations are there, where they go? They go to the visual cortex. Why the visual cortex?
Occipital.
No. Medial aspect of occipital lobe. What is that fissure called? Fissure. Calcarine. Calcarine fissure. Okay. But then you can see occipital is here. And here is the visual cortex. Visual cortex. Sometimes it is formed back like this. You can do the vision. If there is a fracture in the occiput and you use the visual cortex, you can lose the vision. So that then we have the visual cortex. Visual cortex is two areas. One is the primary visual cortex area. What's the area? Area 17. What's that? Broca's area 17. One side. And then there is the visual processing area. That area is 18 or 19 like that. But 17 is the primary visual cortex area. You understand it?
Yes, sir.
So eyeballs, which are optical, it has optical divided into two parts, nasal retinal and temporal fibers. The nasal fibers cross are called orbicula, which will be a pituitary stalk or diaphragm cell. Then it goes to the optic tract. One optic tract of temporal fiber of one eyeball and nasal fiber of another eyeball, and it goes to the left genital body, and from left genital body it leaves a form of optic radiation, and it goes to the visual cortex. And visual cortex is two areas. One is the primary visual cortex, which is area 17, and the secondary visual cortex or associated area of visual area, that Broca's area 18 and 19. What's the association of what is the use of associated area? First, it interprets the information. It interprets the information. Number second is associated with color vision interpretation. Okay. So this was the pattern of the visual part. Why is that? That is speed orbital fissure. There is speed orbital fissure. And there is elements of zinc. And through that elements of zinc go to the orbital organ. So as you know, orbital secondary my explained these four parts of the orbital, and give you the dimensions of so here the visual centers then the bipolar centers no problem, ganglion centers the second order, optical then it goes to optical, then particular. After ganglion cells we have optical left ganglion. Understand? Bipolar cells, ganglion cells, then located in temporal lobe. In the temporal lobe. So these 11 neurons are totally. Here I want to describe some things, some clinical application, some clinical application. So first of all, the important thing is that lateral genital body is in the temporal lobe and the six sets of cells. Six sets of cells. So it's a release station for the visual impulse from where it goes to the brain. So I want to look at this you have understood that there is an eyeball, there is a cortical, there is a cortical, there is a cortical tract, there is a lateral genital body, there is a cortical mechanism, this is the visual body. So you take a peek of this.
Take a picture.
So this is one here, this one here that's called one milligrams group. What's called as one milligrams group. The laser fibers here, there is good point of nucleosome, they bend here like this. That's called 1 milligrams group. That's called 1 milligrams group. This one more that's called Mayer's group. That's called Mayer's group. On the lateral genital body, we have two sets of optic dimensions. One goes to the anterior and temporal. That's called Mayer's group. That's called Mayer's group. And one goes straight to the optic. That is called posterior dimension. Posterior optic dimension. So that goes straight. This goes temporal and then it goes anterior, then it goes posterior. This is called Mayer's. This is called very significant. So here we have some findings. This is supposed to be optical. Then it goes to optical. It goes to optical. From optical, it goes then to optic tract. And this optical is near the diaphragm cell or the pituitary gland. Looks like a So you understand this. Again, the Mayer's group, what I have called the non-milligrams group, I don't know how to call this. This is the laser fiber and this is the band here of fibers. Then they come again and they go to the whole. They bend here and they go straight. They go back. But laser fibers, they bend here and they go straight.
Central scrotum.
And because this will affect these fibers also, this group, what will happen? They represent what? They represent nasal fibers. And mostly they represent inferior fibers. So they will supertemporal loss in the right hand. And in the left hand, they will central scrotum. Because there are central fibers which will be affected. This is called, this bone really varies from this bone. Suppose it comes to the shoulder here, it comes like this. So we will have the central region of this and the inferior fibers that represent the supratemporal spine fibers. Okay, so this is one. Now if you have a digital, what happens? This is the
Nasal. Temporal.
So if you have a right optic nerve part, this whole line will be right. This is region 1. This is region 1. And it will cross over here. Here. Okay? Can I mark it? Can I mark it or not? So this is the region 1. And I have all pointed to it. This is region 1. Huh? This is region 1. Right line. Right line. Now if you have region 2.
सर वो जो पेन है उससे मार डालेगा वो.
It's called junctional tumor. Just immediately so what is it called? It is called left side is the central scrotum and this central scrotum. Because optic nerve begins compress the central fibers. And here you will be a field. It's the head. This is called temporal. Okay. That's on the second line. Third we go to a chiasm. Like this. This was second. And this is the third. Once chiasm, then the fibers will be bitemporal. This is classical. This is classical of what? Classical of a pituitary tumor invading the optic chiasm. So this is like this. So third will be like this. Like this is the right hand, this is the left hand. There will be like this. Okay. This is called bitemporal loss of vision. And it happens in what? In pituitary tumors and it affects the optic chiasm. It affects it. This is called bitemporal loss of vision. Other name is what? Vertigonemus. Vertigonemus heminopia. Vertigonemus heminopia. Vertigonemus. Suppose temporal of this, nasal of this is only. Okay. Temporal of this. This is vertigonemus. It's not symmetrical. Non-symmetrical is called vertigonemus. And symmetrical is called homonemus. So bitemporal will be called So there will be a nasal of this right eye and left eye. Left eye will be what? Left eye का होगा temporal. This and this is more homogeneous. You understand? This is more homogeneous. Homogeneous. So if you are thinking of the optic tract, that will give a homogeneous type. Temporal of one, and nasal of other. So right eye is the right eye here, and nostril right eye, it will be nasal. And left eye, it will be temporal. Okay? So nasal of right eye and temporal of the left. Because you have to remember one thing. Because this optic tract represents the temporal fibers of right eye. So that's opposite, that will be nasal. And it represents the nasal fibers of the left eye. That represents what? Temporal field. Okay. Suppose these fibers come from here, nasal fibers. They will represent the temporal field here. And they here they represent the temporal fibers. They will represent the nasal field. So ipsilateral there will be nasal field, and contralateral there will be temporal. Simple. I have made it simple. So ipsilateral is right region here. The direction of the region or right eye, it will be the nasal field, and the contralateral eye it will be the temporal. So this is demonstrated here. Right eye, the nasal field, and the left eye it will be the temporal. Is it understood? So, then we go ahead. Then these fibers hit the left ventricular body. And from left ventricular body, they go to the optic radiation. They go to the optic radiation. Left ventricular body, you have almost same pattern as this. Because if the optic tract is land with the left ventricular body. Now left ventricular body, it goes then to the optic radiation. Suppose it is in here. I told you there are two sets of fibers here. One is the rears to one is total temporal one. I talked about rears. If they get affected, in which case they will get affected? Temporal surgery, temporal lobe surgery, or ear surgery, they can get affected. Because they go to temporal, then they go to this. So they represent only anterior inferior fibers. They represent anterior inferior fiber. Suppose we take this as the close that layers to here. So if they are affected, so they will inferior. What they will affect? They will affect the superior field. That which type of field? Spine in the sky. That's called spine in the sky. That's called spine in the sky. Good. That's called spine in the sky. Suppose these represent here, they represent here infratemporal fibers. And they will have a fiber in the sky in the nasal rock, nasal field. Okay? So here, we take here. If something is here in the Mayor's room, here is something in the Mayor's room. I don't know how to infratemporal fibers. Okay, this is here infratemporal fibers of the right. Okay, infratemporal fibers, inferior fibers, and on level it will affect the supranasal field that falls quite in this sky. Like this can show. This I will label that is called Mayer's tool. Suppose it will be fifth. So fifth. It will be like this. Why in the sky? So the right side, it will affect what? It will affect what? It will affect the inferior fibers. They will affect the supranasal by the sky. And in the opposite eye, it will affect what? Infranasal fibers, which will cause the supratemporal field. Like this. Here is supranasal part, and here is supratemporal part. The way I told you, the optic tract. Okay? The optic tract I told you that in this right eye, because of the temporal fibers, it will affect the superior nasal field. And in the opposite eye, they are the nasal fibers. They will affect the supratemporal field. That's what I am supposed to say. Here is the supranasal part to the right eye, and here is the supratemporal part. Okay? Understood?
Yes.
Then we have the Mayer's tool. Then there are some of the variations which was taken. This is the sixth. What will happen here? This is the opposite. This is the opposite. This is called pi on the floor. That is called pi on the floor. Why? Because it affects the superior fiber. Superior retinal fiber. So you have those dots. Do you understand now? So Mayer's tool will be pi on the skull and straight optic radiation fibers will called pi on the floor. And consonantal it will be supranasal and consonantal it will be temporal. Okay? But it will be quadrantinopia. What's it called?
Quadrantinopia.
The way we talk about heminopia, we are talking quadrantinopia. So this was here. Now what is the region? So I will take a look. That's the difference. Optic tract is moving front. If there is some damage to the occipital cortex, normally macula is not affected. Macula is not. How the visual field? Nasal from right hand and temporal lobe on the left hand. This central node denotes natural space. That you understand?
Direct and indirect.
Once the optic nerve, optic tract, optic yard, then optic nerve, optic yard, optic tract, some fibers appear before going to lateral genital body. They go to the third nerve, going to the field, polygons. Okay? So, because contributing to that, the afferent is what? Optic nerve. The efferent is
Oculomotor.
so this is how it is done. How you are here from this optic tract, some fibers go to the third nerve and they affect it and they cause memory constriction. Direct as well as the motor. Suppose here the fibers go, they go to the extension, then it goes directly to this and to the motor like that. That's how the direct and the consensual reflection is. That will be. There is no effects. And what accommodation? Accommodation effects comes from what? That comes from the medial reflex. Okay? Once you control the reflex comes from the medial reflex. That will be the whole. That is not the I think that's the
Yes, sir.
Yes, sir.